Thank you very much. It falls to me to talk about chemotherapy. I feel a little bit like the unwanted uncle who comes to Christmas and everyone wants him gone. But as a medical oncologist, what I do want to do is just to have a sense of where we're up to with chemotherapy. I'm not going to dwell too much on IDH1 mutations, FGFR fusion rearrangements, the Wnt pathway. We've had a lot of that over the last couple of days. But really just to overview where we're up to with chemotherapy, I'm trying to focus on anything new that's happened in 2016 and have a sense of where we may be going. And largely, I agree with Joe. So the question really is, has chemotherapy had its day? Should we be moving on to other things? These are my disclosures. So I will touch on adjuvant chemotherapy. I think this year is going to be an important year for adjuvant chemotherapy, and we need to shape our treatments and future trials based on good evidence. Talk a little bit about enhancing the outcome in first-line chemotherapy, briefly on second-line, and then I will also focus on intensification of chemotherapy to the liver and some of the approaches that have been done to try and address that. And I'm not really going to pause and then talk about the future. I want to try and reference to where we're going as we go along. So let's start off with adjuvant chemotherapy. You've heard about radical treatment in terms of surgery, transplantation, and radiation, all very much aimed at a cure, a long-term cure. In fact, there's a lot of information around adjuvant treatment, but the ability of that information to guide how we deliver treatment, unfortunately, is a little bit cloudy. So there was one historical phase 3 study, which was done by Japanese, and in fact, it was including a whole group of patients, including pancreatic cancer, cholangios, and some others. And it did suggest that there was an advantage in favor of adjuvant chemotherapy, but only in patients with gallbladder cancer with mitomycin and 5-FU. There have been a number of publications coming from the SEER databases to try and understand and give some guidance on what the best way forward is. And if you look at extrahepatic cholangiocarcinoma, the initial publication suggested there was no improvement in survival from radiotherapy. Obviously, there have been some other studies that have suggested otherwise. For intrahepatic cholangiocarcinoma, there was an improved survival observed from radiotherapy. The hazard ratio is shown there, 0.82. There was a couple of, in fact, 3 publications for gallbladder cancer looking at the SEER databases, and improved survival was observed with radiotherapy. And in fact, when this was updated most recently in 2011, chemoradiotherapy appeared to have a survival better than chemotherapy alone. And the team at Princess Margaret led on a meta-analysis looking at patients receiving adjuvant chemotherapy and radiotherapy, and looking at a population as a whole, they concluded, in fact, that there was no benefit from adjuvant therapy. However, there may have been benefit from chemotherapy in patients with lymph node positive disease and maybe radiotherapy in margin positive disease. And I think that largely now is what people tend to do in various centers. And we have been waiting for the results of 3 prospective randomized studies. These are specifically asking a chemotherapy question rather than radiation. So there's the French study, Prodige 12, the BILCAP study in the UK, and the Actica study, which is being led by Germany, but is in fact a multinational study. So I will come first of all to the French study, the Prodige 12 study, which was comparing chemotherapy followed by observation alone versus, surgery followed by observation alone versus surgery followed by gemcitabine and oxaliplatin chemotherapy. This study just reported at ASCO GI a couple of weeks ago, so this is very fresh data, and probably we've not had enough time to really digest the detail of what all this means. So let me walk you through this. For this particular study, patients had biliary tract cancer, which included intrahepatic and extrahepatic cholangiocarcinoma. It also included patients with gallbladder cancer who had undergone surgery R0 or R1. Patients had a good performance status, 0, 1, or 2, adequate liver function, and more importantly, patients had recovered in time, so within 3 months, and could then be randomized within the study to either continue surveillance or receive GEMOX combination, fairly standard chemotherapy, oxaliplatin, 85 milligrams per meter square with gemcitabine 1000 and 12 cycles. The randomization was stratified. I think that was important to note, and this was by primary tumor site, so intrahepatic cholangio versus extrahepatic versus gallbladder cancer, involvement of resection margin, lymph node positivity, and by center. I'm not going to show you all the slides from the presentation in the interest of time, just really the headline. And unfortunately, it found that there was no conclusive evidence of benefit. This is the primary endpoint, which was relapse-free survival. The median follow-up of the study was fairly long, 44.3 months. The hazard ratio was 0.83 and a p-value which is not statistically significant. You can see here that, in fact, at the median, there was a separation of the survival curves. With surveillance, it was 22 months as median, and with GEMOX, 30.4 months. I think some observations, and I think we need to look at some of the detail of the study and maybe have some time to digest this. But most patients had lymph node negative disease. So, in fact, 2/3 of the patients did not have lymph node involvement. And most patients had also undergone R0 resections, 87%. So arguably, you could say that these, in fact, are patients who had relatively low risk of recurrence, and it may be that's an explanation for why there was no benefit from adjuvant chemotherapy. Just to quickly look at the forest plots, in fact, if you looked at all patients here at the top, the next one are gallbladder, intrahepatic, extrahepatic seems to be a bit of an outlier on the right. Then you have lymph node involvement, so N0 versus N1 versus unknown, and margins involved or not. So I guess what we're going to try and work out from this study is what does it mean for the various subgroups of patients, and are we able to identify patients who may benefit from treatment, or conversely, patients who may be spared having adjuvant chemotherapy. The hypothesis, in fact, were that they would increase the median relapse-free survival from 18 months to 30 months, and they were about right for the increase. It was 34.4 months, but patients in the control arm did a little bit better than anticipated. And again, this comes down to the detail of the subgroups. So if this study is negative, we then are looking out for the next one, which is the BILCAP study. So the BILCAP study is now nearly 10 years old. It's taken that long to get the study up and fully recruited. It was very ambitious in its design in terms of the patient number, 360 patients. And one of the other things that delayed the study a little was that it really changed the referral pathways in the UK of patients who otherwise would have had surgery and not come to an oncologist. So, in fact, the Independent Data Monitoring Committee reviewed the data and suggested an increase or allowed us to continue recruiting up to at least 400 patients. And in fact, in the end, the study recruited just under 450 patients. I'm pleased to say that the study finally is ready and mature and will be reporting at ASCO this year. The third study is the ACTICA study, and this is still in rollout, so it's nowhere near recruiting 440 patients. I think what we need to do is to await the results of the BILCAP study and see what the implications are for ACTICA. So if we move on to advanced disease in first line, I think it's fair to say that the efficacy of chemotherapy is modest. However, we do need to remind ourselves that, in fact, we now have 3 studies, there's a third one missing here, but 3 studies that have consistently shown that with best supportive care alone, the median survival is in the region of around 2.5 to 4.5 months. So unfortunately, this is a highly lethal disease. We were able to show with colleagues that the combination of cisplatin and gemcitabine improved survival. We initially started off as a randomized phase 2 study. Otherwise, we probably would have started off with a best supportive care arm, but in fact, we started off with a chemo single versus dual combination arm, and were able to show that patients were able to achieve about a 1-year survival, which is better than you do with best supportive care, but as highlighted here, we really need to do better. And there are a number of studies ongoing, and what I've done here is just to highlight some studies to watch. So there are in fact some doublets which are being evaluated. So gemcitabine oxaliplatin versus capecitabine oxaliplatin is a study in Korea. This in fact is the only phase 3 chemo study which is ongoing comparing two chemos. There's the combination of nab-paclitaxel and gemcitabine, which is emerging. And then there's intensification of chemotherapy looking at triple chemotherapy. So 5-FU, oxaliplatin, and irinotecan in the modified FOLFIRINOX, GemCis and 5-FU, or GemCis and S1, which is the preferred fluoropyrimidine in Japan. Just to quickly focus on a couple of this, this certainly looks interesting in Japan. The original phase 2 study on which this is based did see an overall survival of 16.2 months with triple chemotherapy. So it'll be interesting to see what the phase 3 study does, comparing it to the backbone of cisplatin and gemcitabine. At ASCO GI, just very recently, this study was presented, and it was looking to try and personalized to a degree systemic chemotherapy, and was looking at UGT1A1, which, as you know, polymorphisms of UGT1A1 affect the way that irinotecan is metabolized. And so there were dose modifications for the irinotecan depending on the UGT1A1 polymorphism expression by patients. Unfortunately, despite that, modified FOLFIRINOX in this particular study was felt to be too toxic and was not tolerable in patients with biliary tract cancer. There is certainly a concern with biliary tract cancer where the risk of infection, neutropenic infection, is very high to be going in with regimens that are highly myelosuppressive and can cause problems with life-threatening infections. So I think we need to just see how these triple chemotherapy studies unfold and whether we should be going with triple chemotherapy or whether we should be sequencing our chemotherapy drugs into 2 or more lines of treatment. What about new drugs coming along? So the team at New Canna have been developing a new version of gemcitabine with a ProTite technology. So just to remind you, gemcitabine has to be accessed through HENT, which has to be expressed on the cells. Once it's inside the cell, it's metabolized to monophosphate, diphosphate, triphosphate, and then it's active, causing cell death. And through cytidine deaminase, there are some metabolites which can be responsible for some of the toxic effects. The new compound acelerin is in fact already a monophosphate. It does not require HENT to access the cells, so it's HENT independent, and once in the cell, rapidly goes to the diphosphate and triphosphate and doesn't get broken down by CDA and doesn't produce some of the toxic metabolites. So in theory, it should work better and it should be more tolerable. What the team have been able to show through the phase 1 studies is that acelerin achieves over 200 times higher intracellular levels of gemcitabine than the standard gemcitabine, and that's shown here on this bar chart. And in fact, acelerin also achieves a much higher AUC, 140 times, or just under that seen with gemcitabine intracellularly. In the phase 1 study, there were some patients with cholangiocarcinoma that were included. You can see them highlighted in green. And in fact, the team were also able to demonstrate that there was one patient who'd been previously treated with gemcitabine who then received acelerin and had a response to treatment. So at the moment, there are a number of phase 3 studies that are planned in ovarian cancer, pancreas cancer, and biliary cancer. And it's really the latter that we're helping to lead on in the UK. So because acelerin hasn't yet been combined with cisplatin, we have to do a run-in phase 1b study. And the starting dose was standard cisplatin 25 milligrams per meter square, 625 milligrams of acelerin. It's a fairly standard 3+3 phase 1 escalation study. And if you want an update, we've now recruited 8 patients. And we've just gone from cohort 1 and dose escalated to cohort 2, wherein patients will be receiving 725 milligrams of acelerin and cisplatin. This is an important study because it's planned to rapidly move on to a phase 3 study. The team at Princess Margaret in Toronto are pretty much on standby with a protocol ready to compare that head-to-head with cisplatin gemcitabine. So what about second-line chemotherapy? I think Maeve and some others presented at this meeting last year some of the results of second-line chemotherapy, and it very much fits in what we were able to see from our systematic review, which in fact was published in 2014. What the systematic review was able to highlight is that in fact there are many patients who participate in studies or series. So there's nearly over 800 patients here who've taken part in 23 reported studies. And you can see there's a whole smorgasbord of different chemotherapy regimens and combinations. And unfortunately, we were not able to conclude following that review which was the best approach. It was clear that patients were available for clinical trials, and we did need to focus on practice-changing questions. And it's really on that background that we decided to develop a chemotherapy question around whether we should be using chemotherapy in a second-line setting. So this is the ABC06 study, wherein patients who have received previous cisplatin gemcitabine chemotherapy, and we've kept the population very homogeneous, so no other chemotherapy regimens are allowed. We know that these patients very frequently succumb to problems of biliary drainage, superadded infection, the need for a stent, a second stent, a third stent, with all of those very challenging complications that we all have to deal with. And very often, it's these infective complications that can be more life-threatening than rapidly progressing disease to other organs. So we've deliberately not called it best symptom control. We've wanted to be very much a hands-on approach, active symptom control, monitoring patients actively, monitoring inflammatory and infective markers, pouncing on them when they're happening so that we are able to get these life-threatening complications under control. And then over and above that, the question is whether adding chemotherapy, in this case with oxaliplatin and 5-FU in the FOLFOX regimen, improves survival. So just by quick way of update, this is where we're up to with the study. We've now recruited, in fact, I've heard from our trial coordinator today, we're now up to 120 patients out of 162 which are planned, so we're now 74%, nearly 3/4 of the way there. And judging by our recruitment rate at the moment, we will complete recruitment in October, November later this year. We're delighted that the foundation has sought to fund Trans ABC06, which is a translational question that we're adding in around understanding the role of DNA damage repair mechanisms, given that platinum is being used both in first line for eligibility for patients for this study, as well as in the second line setting. So I was going to then move on to intensifying chemotherapy within the liver. You've already heard a little bit about this and seen this image before from Johns Hopkins about transarterial embolization therapies for unresectable. And this again is focusing on patients with intrahepatic cholangiocarcinomas. In fact, there was a quite nice review, a meta-analysis in 2015, I beg your pardon, it's a review. The data could not be meta-analyzed because of the variable quality, but they were able to identify a total of 20 studies, included 7 studies with radioembolization with close to 1,000 patients. Unfortunately, they were not able to identify a randomized controlled trial. Most patients had bilobar disease. A third had extrahepatic disease, and a third had prior chemotherapy. The described pool response rate that they saw was around 28%, time to progression 8.2 months, overall survival of 3 months. But I think what's important here, and is a reminder to all of us as oncologists, is that we do need to revisit the question about whether a patient may have been rendered suitable for surgery depending on a response to any therapy, whether it's a local regional therapy or systemic therapy. We need to take these patients back to the tumor board and discuss whether surgery is now an option. They were able to identify that patients had a worse prognosis depending on multiplicity, localization, and vascularity. And again, there was a number of different regimens, and it was difficult to work out which was the most appropriate chemotherapy. So that was really just to herald this study that was published in 2016, looking at intrahepatic arterial chemotherapy. So no longer with the embolization, but with the chemotherapy. This has come from the team at Memorial. And you know, for a while they've been using hepatic arterial infusion, continuous infusion, FUDR, and this is given over 14 days, repeated every 28 days through an implantable portal pump. And what they did here is to look at the patient flow of patients with unresectable intrahepatic cholangiocarcinoma, 236 in all. And here is a group with distant metastases, here liver-confined disease, and here regional nodal disease. So if you just think about liver-confined disease with no lymph node involvement, there were in fact 104 patients. And this is the survival curve. You can see the overall survival was 30.8 months compared to 18.4 months in favor of patients receiving intrahepatic arterial continuous infusion chemotherapy. The response rate was also higher, 60% compared to 40%, so a 20% difference in response rate. But there are some limitations which I think are quite important to bear in mind. Of course, there's a retrospective, it was single-center series, and that has limitations of its own. But I think the biggest difference was that there were differences in staging. So patients who had the intrahepatic arterial chemotherapy had to have a port implanted. That means that they had an operative procedure which was then able to identify occult metastatic disease. Patients receiving systemic chemotherapy on the whole were staged radiologically, so there was definitely a difference in staging there. The chemotherapy that was given systemically was not standardized, so again, it was a number of different options. And the question then is, you know, if we are going to pursue this approach, is there an optimal combination that we should be thinking about targeting the liver and then giving systemically? So I think we do need to address some of these questions, and this is subject to confirmation in a randomized clinical trial. But if you really want to intensify chemotherapy to the liver, this is what's coming around the horizon. We were delighted to have the team from Delcath speaking at the industry night last night to give us a little bit of an update. So the principle behind here is that you have, in fact, two sets of balloons. So you're familiar with the chemotherapy delivery catheter, which then goes into the liver and delivers the chemotherapy into the liver. But this has a separate catheter that's in the femoral vein on the right side, goes up into the IVC. This is blown up here, and then it effectively isolates the liver. So you have a pump up here and a pump down below, and that means that you can then infuse the chemotherapy into the liver. You flood the liver with chemotherapy, and if all that chemotherapy went into your systemic circulation, you would die. So what you need to then do is to filter it all back out again. And the team are now on their second generation filter, which is able to filter out 97–98% of the drug that's infused. Now that effectively is then treating the liver as a whole organ, rather than what we sometimes do is treat part of the liver, either segment or lobar. This is now flooding the liver with chemotherapy and removing it all again afterwards. The drug being used at the moment is melphalan. Now, that's not a drug that we would normally associate with GI cancers or even cholangiocarcinoma. In fact, melphalan is just a very active drug which has got a very narrow therapeutic window. And one of the advantages of taking this approach is that by removing all the drug afterwards, you can then expose the cancer to an alkylating agent and then see what result you get. That's the theory. The practice has been proven to be the case in a cancer called ocular melanoma. Ocular melanoma is not like cutaneous melanoma, doesn't have all the treatment options that cutaneous melanoma has. And in fact, ocular melanoma does have a high risk of spreading to the liver. It has always been considered an untreatable condition just because it's refractory to any treatment. And in fact, the team have been able to show that with this chemosaturation, you can actually get very good control, quite impressive responses from a disease that was previously thought to be untreatable. So what's happening with respect to this in the future? There will be a study coming along the horizon which will be evaluating this in a randomized study comparing chemosaturation, which can be repeated alongside cisplatin gemcitabine chemotherapy, and that will be compared to cisplatin gemcitabine alone. But we are in an era of precision medicine, and we probably need to be thinking about somehow moving away from chemotherapy, which is pretty much a blunt tool. We've been here before, so we've got fairly excited about targeting EGFR, particularly based on the results of a very promising study which was led by the surgical team in Austria. High response rates, high number of patients went to salvage surgery, but unfortunately there have now been 4 randomized studies which have all failed to show an improvement from the addition of EGFR inhibition with either cetuximab, panitumumab, or erlotinib. So I think there are still lessons to be learned, and maybe we can't extrapolate the lessons that we've learned from other types of cancer, like colorectal cancer, immediately to cholangiocarcinoma. This is a very busy slide with a cartoon, which is a variation on a theme that you've seen over the last couple of days, looking at the various pathways as well as where we can target these. So EGFR, you've heard about FGFR fusion rearrangements, IDH, Notch and Wnt pathways, and so on. And we are hopefully having a better understanding of the biology of cholangiocarcinoma, identifying where we can target these, having the drugs that we can target them with. But what we need to really understand is, does blocking a particular pathway really lead to an improved outcome? Understand better through multiple sampling, maybe using liquid biopsies, how cancers become resistant to these therapies. And we heard some of that in the FGFR setting yesterday. And more importantly, being able to identify groups of patients, again, who have benefit or particularly do not benefit from these treatments. One of the issues raised earlier was around heterogeneity. And this is something that we're going to have to address at some point in the future, and probably on an ongoing basis. So you've got a primary tumor here. You have founder cells, a subclone, which is blue, subclone 2, which is yellow, subclone 3, which is green. And as you can see, these all look very different, and there can be intra-tumor heterogeneity, intrametastatic heterogeneity, and intermetastatic heterogeneity. And one of the challenges is going to be, how do we understand this? How do we move to address this with our therapeutic strategy going forward? You're deliberately not able to see this, but I'm hoping it illustrates the number of clinical trials that are coming through in cholangiocarcinoma, both in first line and second line. I just want to quickly highlight one of these studies just because of the efficiency of the design. So this is the JSDF study, which is being run by Lilly. It's a randomized phase 2 study which is evaluating ramucirumab targeting VEGF and merestinib targeting c-Met. If we were going to do a randomized study just looking at one of the agents, so ramucirumab here, we would do 1-to-1 randomization and 50% of the patients would be receiving placebo. Similarly, we could do that with merestinib, 1-to-1 randomization, 50% of the patients would be receiving placebo. However, by combining these two into one study, what we're able to do, is to have 2-to-1 randomization for this question, 2-to-1 randomization for this question. And in fact, by doing so, we can pool the patients who are receiving placebo and having the chemotherapy without an active drug, and effectively only a third of the patients are then having a placebo. Turn that around, we're optimizing the percentage of patients who are able to access a novel agent. So Last year, I was arguing in the debate for the role of chemotherapy as one of the pillars, together with surgery and radiotherapy, in the management of cholangiocarcinoma. I think it's getting a little bit more complicated. I think we now have more pillars. And I think what we need to do is now factor in some of the molecular targeted therapies, immunotherapy. But as you can see, 3 pillars alone would not have maintained that particular building. So with that, I just want to wrap up with my take-home messages. I think chemotherapy, I hope I've argued, remains one of the pillars of treatment. We do need to improve on that. So far, it improves control in advanced disease, and we need to evaluate further what it does in the adjuvant setting. We do need to improve and get more effective systemic therapies, and we need to apply the emerging genomic technology, assess profiles promptly and critically, understand what new targets mean, and translate these into new drug development. I think we need to be moving towards more and more efficient and innovative clinical trial designs to be able to rapidly get these through to our patients. And I hope what this session has been able to highlight is the importance of, again, the multidisciplinary team in managing all of these patients. Thank you very much.